electrolytes. Proteinuria.
Okay, so urine analysis. Okay, definitely, yeah. What else? In terms of measured parameters. First years?
Urine output.
Yeah, very good.
GFR.
Very good. Very good. Okay, yes, you said all those things as if I primed you. Okay, but common parameters in which the way we assess renal function starts off with line and swipe. Yes.
Thank you.
So we have the creatinine, and then we have urine output that we can consider. Like you all mentioned, we have EGFR, which represents your estimated glomerular function, filtration rate. And then we have creatinine clearance. Okay, just to touch on this, what is creatinine? Anyone? Medical students first? Take a guess. First year residents?
Breakdown product of protein,
Yeah, it's a breakdown product, right? A protein and or
muscle mass,
muscle destruction, right? So in what kind of situations do you think that creatinine may not be properly representative of someone's renal function?
Post-workout.
Weightlifters?
Post-workout.
You said post-workout when there's excessive muscle breakdown?
Or
Okay, and in the opposite scenario to that we might see in the hospital?
severe malnutrition,
Yeah, exactly. Or what about your like 70-year-old female who's got like no body mass? Right? Will it really be a true reflection of her underlying renal function? No. And then we talk about EGFR. It comes up every day in our BMP. We probably don't even look at it particularly. But what is EGFR? Does anyone know? You're saying it in whispers. Yeah, estimated glomerular filtration rate, right? Did you know that this is actually just an approximation and that this is actually different from your measured glomerular filtration rate, which is the more accurate way of doing this? What are the variables? Does anyone know that are involved in calculating EGFR? Take a guess, you're probably right. I know you want to say something. Creatinine, wonderful. Okay, creatinine is in there, yes, awesome. And then age is also in there, gender is also in there. Interestingly enough, race is also in there. So I'm not sure how our computer is able to contabulate that when it comes up in our daily results, but nevertheless it is there. What is creatinine clearance? Anyone? This is how well, it's another measure, right, of how well the kidney is functioning. Why is it relevant? First year residents, why is it relevant?
well, your medication dosages will change based on that for a lot of them.
Yes, wonderful, it will. What do you think are the parameters involved in calculating your creatinine clearance?
Yeah. You're going to get your GFR, you get your GFR, you get your urine, sodium, and urine, and then urea level, plasma urea, and assuming you have your other numbers in the serum
You've got your
to
age,
calculate.
you've actually got patient weight,
Yeah.
serum creatinine again, and then there's a multiplication cofactor for men and women. Okay? So again, there's just a little bit of awareness of how we can assess the renal function to start off with. What about how we actually define acute kidney injury? Okay, what do you guys, is there a definition? Is it just any change in the creatinine? What do you think?
KDIGO staging.
There's KDIGO staging, okay? If you know that much, I'm going to ask you to just hold. Medical students, do you know if there's any formal definition for AKI?
Is it a change in the baseline, like 40 or 30%? I can't remember.
So change in the baseline is definitely there, okay? And then thinking about what we just said is the ways of which we can assess kidney function. What else do you think is there as a practical, everyday, day-to-day measure that we can do?
Output, GFR.
Output, okay? Urine output is definitely one of those factors there. So I'll put you out of your misery, or does anyone else want to say it? First years?
rise in creatinine 0.2 per day over from baseline over 48 hours.
So that's one of them, okay? Increase in your serum creatinine, okay, more than 0.3 within a 48-hour window. So sometimes if the patient has been in ED before, in the last couple of days, and then they come back, now the creatinine is significantly elevated, you have something to compare to. Or if you know someone from in the office and you're seeing a significant baseline increment of more than 1.5 times their baseline, or if you're in the hospital and you notice that someone's urine output is falling below 0.5 ml per kilo per hour for at least 6 hours, okay? This is the actual definition from KDIGO about what AKI is. There are some other staging criteria from other groups, but you don't need to go into all of that. This is roughly what we need to take away with us. So is all AKI the same? What do you think? First year residents, what do you think? Is all AKI the same?
I need to classify.
Within their class? Hands up if you think there is classification of AKI, or do you think it's all just one group? Is it one group? Hands up. No one thinks it's one group. Really? Sure? Yeah, you're all right. Yeah? It's not just one group. There are stages, and again, KDIGO will go into that in terms of what is mild, moderate, and severe. Okay? And that becomes a little bit relevant when we talk about what is going to be the further management of the various patients within this category. So I've tried to put it in a simplified table here for you. Stage 1 is clearly your mild cases, stage 2 is going to be moderate, and then stage 3 is going to be your more severe. So you can see if you go from one group to the other, the amount of which your creatinine has incremented from baseline increases substantially in each group, and or the urine output will drop, okay, and for further times. If you're completely anuric, you go straight into you go straight into stage 3, okay? Or if for any reason you have to have renal replacement therapy, again, you'll go straight into stage 3. So we've understood a little bit about the definition of what AKI is and the fact that there are stages within AKI itself. What do you think would make the difference? So again, according to KDIGO guidelines, if you've got stage 1, these people are mainly going to be managed in an outpatient setting unless and until you don't know what the trigger was, or you anticipate that because of their other comorbidities, this is likely to get worse exponentially. Aside from that, stage 2 and stage 3 usually require inpatient management, okay? So that's why it's kind of a little bit relevant to know in your mind that there are different subcategories. So before we go any further into AKI, I told you it was a broad term covering lots of different ways in which the kidney function is affected. Let's talk a little bit about anatomy so we can understand how that is possible, okay? So medical students who are much closer to this than any of us, okay? We're going to talk a little bit about just the anatomy of a nephron. How many nephrons do you think there are in each kidney? Give a rough guess. A billion, he said. Any takers on a billion?
1 million on each kidney.
1 million, okay, so a little bit lower, yeah. It's on average about 1 million nephrons in each kidney, okay, which is an amazing number if you think about it, right? Like that's just, I think it's amazing. So when we look at the general concept of what a nephron includes, you have your glomerular capsule, you have your proximal convoluted tubule, then you have your loop of Henle with its descending and ascending limb, and you have your distal convoluted tubule which ends into your collecting ducts. Okay? No real shockers there, everyone remembers this much. But most of the anatomy or most of the trouble that the kidney can get into is based on perfusion. So let's talk about blood supply, okay, to the kidney. So who wants to educate us on that? I need a volunteer from the medical students. Do you want to come up because you're just right here in the front row? It's okay, don't worry. I'll be right here and I'll help you out with this. It's okay, come on up, come on up. Yeah, you'll be fine. You'll be fine, trust me. I'm not going to put you on the spot. What is your name? Eve. Okay. Eve, I happen to know that you're going to be amazing at this. Why don't you try sliding the screen across? Wow, how did you do that? Yeah. So this is going to take us a little bit into the blood flow. It's just good revision for all of us. Okay, so you have your abdominal aorta. It breaks off into your renal artery, and then you've got your segmental arteries here that travel between pyramids. You have your interlobar arteries, and then arching around you have your arcuate arteries, which then develop your interlobular arteries, from which arise your afferent arteriole, right? That's the actual supply then that interacts first now with the glomerular capsule. That forms the glomerular capillaries within there, and that then that then joins on with the efferent arterioles. So this gives you some understanding of how blood flow is delivered to each individual nephron. Okay? Clear? Aside from this now, you should understand that perfusion is linked, okay, into renal function. But there are causes in which intrinsic kidney disease can cause AKI. And in order to understand that slightly better, we then appreciate what the physiology and the apparatus around the glomerulus is. And I hope this works, but I don't think it will. Is it going to work? Somebody help? How did we get it?
Can you mouse it as a microphone?
Can I?
Is there a mouse?
2 fingers?
Press.
Keep it keep it pressed.
What is press and hold?
Oh, a red button.
Maybe 2-finger clip?
I don't even know how to close this down to open another window.
Try it with 2 fingers.
2 fingers.
Yeah.
Oh, yes. That was
Still
genius. Who
probably
said
is
that?
voting for Anna.
No, someone back there said it. I didn't have to. It was
Okay.
The glomerulus is an interesting and complex structure. Arguably,
Oh, you opened it 2 times.
Weird.
the glomerulus is an interesting and complex structure. Arguably, the most important part of the kidney. In the sense that most disorders of the kidney involve the glomerulus. The glomerulus regulates renal blood flow, glomerular systemic blood pressure, and sodium regulation by the kidneys. In this micro lesson, we'll limit our discussion to the basic structure of the glomerulus and the cells that make up the glomerulus. To start with, the glomerulus is composed of 3 different cell types: endothelial, smooth muscle, and epithelial cells. Like the vasculature throughout the body, the afferent arterioles, the glomerular capillaries, and the efferent arterioles are lined with a single layer of endothelial cells. However, the endothelial cells that line the glomerular capillaries are unique in that they have pores or fenestrations that measure 70 to 100 nanometers in diameter. These fenestrations allow for the rapid filtration of water, solutes, and electrolytes, while restricting the passage of blood cells and large molecules like proteins. Surrounding the endothelial cells, the afferent and efferent arterioles, are smooth muscle cells. They influence the glomerular filtration rate by regulating the vascular resistance of these 2 arterioles. Besides the typical smooth muscle cells that surround the arterioles, the intraglomerular mesangial cells, extraglomerular mesangial cells, and granular cells represent specialized smooth muscle cells. Each has a distinct function. Situated between the glomerular capillaries within the Bowman space, the intraglomerular mesangial cells influence the glomerular filtration rate by regulating the glomerular capillary surface area. They do this by altering the state of contraction and relaxation. The The extraglomerular mesangial cells, as their name implies, are located outside the Bowman space and are situated between the macula densa cells and granular cells. They respond to chemical signals that originate from the cells of the macula densa, which influences the release of calcium ions, which then spread to granular cells and typical smooth muscle cells via gap junctions. In granular cells, calcium suppresses the release of renin. Renin plays an important part in the renin-angiotensin-aldosterone system, which influences systemic blood pressure, renal plasma flow, and sodium reabsorption. In typical smooth muscle cells, calcium facilitates the contraction of the myofilaments, which leads to a reduction in the renal plasma flow and ultimately a reduction in the glomerular filtration rate. The cells that form the capsule that make up the Bowman space are referred to as parietal cells, which are a specialized epithelial cell type. The Bowman space is a cup-like structure that surrounds the glomerular capillaries and is designed to collect the ultrafiltrate. Once formed, the ultrafiltrate drains directly into the tubule. Podocytes are also specialized epithelial cells and are located in the Bowman space. They form extensions called foot processes, which completely surround the glomerular capillaries and play an important role in restricting the passage of plasma proteins into the ultrafiltrate. Now, the space between the foot processes is referred to as the filtration slit, and it measures approximately 30 to 40 nanometers across. The filtration slits are held together by a number of integral membrane proteins like ZO1, nephrin, and podosin, just to name a few. These integral proteins act like intracellular tight junctions and restrict the passage of plasma proteins, as well as maintain the structural integrity of the foot processes. Loss of these proteins often leads to the appearance of protein in the urine, otherwise known as proteinuria. Together, the endothelial cells and podocyte foot processes secrete extracellular matrix proteins that form the glomerular basement membrane, or GBM, which is composed of matrix proteins like collagen and heparan sulfate. The GBM measures approximately 250 to 350 nanometers in thickness and has three distinct layers, or lamina. They are the lamina rara interna, which lies next to the glomerular capillary endothelial cells, the lamina rara externa, which lies next to the foot processes, and the lamina densa, which lies between the lamina rara interna and externa. The primary function of the glomerular basement membrane is to restrict the passage of plasma proteins and help maintain the structural relationship between the glomerular capillary endothelial cells and podocyte foot processes. And finally, the macula densa cells are specialized tubular epithelial cells that influence the regulation of glomerular filtration rates. The macula densa cells are technically not part of the glomerulus, but because they influence glomerular function, they are often referred to as the juxtaglomerular apparatus, or JGA. For more on the role of the macula densa cells, see our microlesson on the tubular glomerular feedback mechanism.
You said two fingers. How do I go back to my
Bottom right.
Minimize.
Unfull screen.
Thank you so much. Okay. So the idea behind showing that short animation, other than I thought it was a very good talk in the ways of components of describing what is within the glomerulus, is to also help you to identify and start thinking about which parts of the glomerulus can be diseased and contribute towards intrinsic causes of renal failure. Now, what are going to be our causes or our thought process when we're thinking about acute kidney injury? Medical students first.
Yeah, I was like,
Shout it out, Eve.
Post-renal versus renal?
Yes. This approach has not changed for ages, since the dawn. Okay, so you've got pre-renal, renal, and post-renal, which is partly what's written down here. I don't know if you guys can see that from wherever you are. Eve, why don't you come up and be my scribe? we're going to ask for 5 causes from each of these subcategories as to what can cause renal impairment. So starting from the medical students, what pre-renal causes can you think of that might lead to acute kidney injury?
Infarction. Or like, decreased blood flow. Yeah.
But from,
Or like renal artery stenosis or something like that.
okay, so hypovolemia from some sort, okay, so that's going to be your first.
Would you want me to put it right under?
You could just put it, you could do what you like. Okay, so hypovolemia. It's kind of a broad subcategory, right? But what would cause the hypovolemia commonly? All right, so hemorrhage they've got sepsis. You can put those down. What's more common? Yes, dehydration, okay. Just usually what are people doing when they come to the hospital? How are they losing that volume? Yeah, like some GI loss, right? What about, can you think of any renal causes? What's the most common renal cause, do you think, of acute kidney injury in the hospital? Okay, but so if those toxins, what is the medical term for that? What is actually happening in the kidney? Do you know? Yes, acute tubular necrosis. Okay, so ATN is going to be one of them. What other causes? What other common, really common systemic problems affect the kidney?
Cirrhosis.
Okay, he said lupus. That's great. But what's more common than that? Like the every Joe blogs on the street has. Yes, hypertension, diabetes. They just need one more. Residents, you can help out now. Intrinsic renal causes. Okay, so they talk about drugs. What?
AIN.
Rhabdo, AIN. What about post-renal causes? Obstruction from what? So some sort of GU tract stone, okay? BPH, yeah, that's a good one. What else? Tumor. What else? Strictures, yeah. Okay, yeah.
That could cause post-renal.
So we've got 5 in each of these subcategories, right? Eve, you happy with these answers? Yeah?
And if we have a renal infarction, that would be under renal. Renal being thrombosis, acute.
Round of applause for Eve, guys. Thank you for being a good sport. Thank you. So the idea behind this exercise is just basically A, to get some interaction, and B, so that you can realize there's a broad spectrum of things that can damage the kidney. And although we think about it in pre-intrinsic and post-renal fashion, it is not uncommon to have one thing from multiple subcategories affecting the kidney. And I had pretty much the same ideas as all of you guys had in terms of the approach. So you guys mentioned ATN and AIN. Pre-renal and post-renal is fairly self-explanatory, but the majority of patients in hospital will go through either ATN as their intrinsic cause of acute kidney injury. So it's worth just talking about it for a second. And I've put in AIN here as well, just as a bit of side information too. So if we first talk about ATN, there are two subcategories. One is direct ischemia related, and the second is mediated from direct nephrotoxin use. And as you see, that there are going to be usually three phases within the natural cause of this. You're going to have your initiation, the maintenance of this phase, and then the recovery phase. Treatment is mainly symptomatic, and you'll see, of course, the renal impairment. There'll be a high urine sodium load because the tubules are diseased, so filtration and reabsorption is impaired, right? And classically, although not always, you will see granular casts and muddy casts on urine microscopy, okay? How that compares and contrasts with AIN. So a lot of you said medication, direct medication use. Just be conscious of the fact that medications can lead to AIN, or they can act as direct nephrotoxins on the tubule cells, okay? In AIN, again, medication being the most common cause, it can also be triggered by systemic infection, toxin ingestion, and certain autoimmune conditions. What will you see again on lab findings? You won't always see the classical trilogy of rash, fever, eosinophilia, but if you do, it's pretty pathognomonic for this. Urinary studies, people used to think that eosinophils will always be there, but more recent data has shown that that is not sensitive or specific and not recommended to be screened on urine analysis. And the treatment lies around stopping the offending drugs. What are the three most common offending drugs for AIN? And?
PPIs.
Yes. And if you didn't know, you could have just read it there. Okay. So antibiotics, PPIs, and NSAIDs. And if that's not drug mediated, then obviously treating the underlying condition will help treat the AIN. So how are you going to approach the workup for this? Medical students first. A CMP. So before that, let's back up. You've got a patient. What do we start every workup with? Before the history, before the physical, the history. Yeah, wonderful. And what in the history do you think is pertinent?
Medications.
So medication for sure.
Changes in urine.
Yes, changes in output. If they've noticed, many people don't really keep a record of that.
Chronic medical conditions.
Yeah, comorbidities for sure. And then you're going to go through this thought process, right? Like, do they have any triggers to think about pre-renal? Do they have any post-renal features? Have they got any existing kidney disease? The medication history is all particularly relevant. So I put up some thoughts here for that. What about in your physical? What things will you see or to try to look for? Volume status, great. That's one. What are the physical findings relevant? CVA angle tenderness, okay. And then as you feel the abdomen, if you feel a distension of the bladder, right, is quite common. Then what else? Sometimes if you're lucky and you've got a typical rash, which might lead you to think about a vasculitis or something like that, it may also be contributory. All right. So these are the main things. Of course, we know that AKI is seen commonly in lots of other presentations. So this is just about pertinent things that might hint towards a cause of the AKI. Oh, what about investigations? What do you want to send off for? Start off with a CBC, I'll give you that one for free. A CMP, okay, that's great. The urinalysis is useful. What are you going to learn from your albumin-creatinine ratio? From an albumin-creatinine ratio?
Albumin. The creatinine over 21 is pretty.
Yeah, if you wanted to, you could sum up urinary electrolytes and work out a FeNA. right? So I think I put there CBC, CMP, some electrolytes, urinary studies, which we'll talk about in latter slides. What imaging might help you, if any?
Ultrasound, X-ray.
So let's start with basic by the bedside. Is there anything you can do? By the bedside, on the floors.
Bladder scan, right?
Yeah, bladder scan, right? That's the easiest, cheapest thing. Have you guys ever seen that? So every nurse, you don't need any training whatsoever. You have like an ultrasound probe. They put a bit of jelly on it, place it where the bladder is, and if you move it around there, it will scan the volume in the bladder. Okay, so if you're not sure that someone has acute retention and you want to confirm, you can do a bladder scan by the bedside. So next time you're on the floors, ask them to see that because every floor has one. And then you guys mentioned ultrasound, okay? And then you also mentioned CT, KUB, as and what you think the underlying cause is. All of these imaging modalities are useful, all right? What about another thing to think about? So you've done all this workup. Some people are very serious, right? They might have stage 2, 3, advanced kidney disease, or something about their presentation that makes you think their medical therapy alone is not going to be enough, all right? What kind of categories, or do you know what to look for if we're thinking that someone needs perhaps dialysis?
Yeah.
So you said, say it loud, say it proud.
Uremia.
Yeah, so symptomatic uremia, okay? All right, what else?
Hyperkalemia, electrolyte abnormalities.
Yes, is it any hyperkalemia?
No, I think it has to be above like 6.5.
And is it the first time you see 6.5? Are you going to get on the phone?
No.
So refractory hyperkalemia, right? Absolutely. What else?
Rhabdo.
Significant rhabdo, perhaps, but not always. Okay. Any other ideas? Do you guys have a mnemonic or anything in mind?
Yeah, the AEF.
Yes. Yeah. Come on, man. You guys know it. Help me out here.
Acidosis, constipation, overload.
So A for acidosis, E for electrolyte abnormalities. Okay. And then the I is for ingestion of toxins, right? Toxins which may need dialysis. And then what's the O for? Volume overload, awesome. And then the U is for uremia, symptomatic uremia at that, okay? So that's a really good mnemonic to have in your mind whenever you're assessing anyone who's got underlying AKI, because that's going to change your management and your approach plan completely, okay? Question for the first year residents, some of whom have lost their attention in this talk. Okay, guys, what things can we do as an interim approach before we consider dialysis in acidemia? You've all seen acute kidney injury. What else can we offer? Say it?
Sodium bicarb.
Yeah, sodium bicarb, okay. And are you aware of like what the target ranges of bicarb are? What are you trying to get your target? What are you trying to get it to?
Would have to be bit more than 18.
So 20 to 22, or if you do nephrology here, they'll say above 22. What are you trying to get your pH to be?
More than 7.5? 7.5?
It should not be less than 7.1.
It's like the urine pH, right?
At least 7.2.
So you want to try to keep that pH above 7.2,
7.2.
right?
Oh,
Okay, so these
Oh,
are
I'm
your
thinking of
targets, and that's what you're trying to achieve. If you cannot achieve that with medical therapy only, or if there's some other reason, that's another indication for acidosis. What about, so in hyperkalemia, how do we manage that?
Insulin.
Insulin, dextrose, okay. When are you going to use calcium?
EKG, we go for EKG.
Around 6.5.
If we find an EKG.
So it's in EKG changes, right? And then, what did you say?
Potassium is more than 6.5.
Yeah, so then we're gonna treat, but what else can we use? So we've used insulin dextrose, what else can we give? Yeah, so some sort of binder, right? Okay, we can use. What else are we gonna do then? We're not gonna stop there.
You can use beta agonists and bicarbazole.
Okay,
Loop diuretic.
Salbutamol. Albuterol.
so yes, these are all temporizing measures you can use. What about thinking about the actual underlying cause? So we'll stop any drugs, right, that they are on that will promote hyperkalemia. Otherwise, we'll never come out of this circle. Okay, and then if it is refractory to these measures and to other things that you've tried for long enough, then again you will dialyze. Ingestion of various toxins is self-explanatory. Volume overload and symptomatic uremia. What kind of symptoms will you have with uremia? Encephalopathy, awesome. Asterisk, okay, that's a physical sign.
Very far.
Pericarditis,
Nausea, vomiting,
yeah.
weakness.
You can have some itching, yeah, severe, like it's very severe. So these are just some of the ideas, okay, to have in our minds. So a lot of the times when we're presenting patients with acute kidney injury, we talk about what their FeNA is. Now, FeNA is actually looking at the percentage of how much sodium is present in our filtered urine, okay? And we use it as a marker because usually if everything is working well in your kidneys and you have, if everything is not working fine, so you have any pre-renal cause, the compensatory mechanism for that is the body will try to hold on to whatever sodium there is, okay? Because we're trying to maintain our volume. And you know wherever sodium goes, fluid follows, okay? So if you can keep that kind of understanding in the back of your brain, that will explain why some of these FeNA results the way they are. So we know that if you have a FeNA less than 1, it's likely to be pre-renal. And if you have a FeNA more than 2, you're thinking about ATN. And that's really where the role of FeNA comes, when you're not sure if someone has a pre-renal cause or ATN as their cause. But it's never that simple, okay? So in a lot of these guidelines, they talk about not using the FeNA in isolation. And what category of patients is FeNA most accurate in? Do you know? Second year residents. What subcategory of patients is FeNA most useful in?
So those are
Non-diuretics and
Non-diuretics, AKI,
Doesn't it say that right there?
yes.
That's right.
So it's most accurate in those people who are oliguric, okay, and who have a more significant drop in their GFR. It can sometimes be confusing if people have otherwise intrinsic kidney disease, or if the degree of their AKI is not as severe, because this, like all things in medicine, is not a step rule, okay? There will be some other causes that give you a low FeNA which are not pre-renal. So it is to be taken with a pinch of salt and an understanding that there are other impacts on this value. But if you, for example, do have someone who's got very severe acute kidney injury and has come in on diuretics, what else can you look at? So you mentioned that it can't be used. What else can you do? If it's not FeNA, it's Furia, yeah. Okay, and again, we know that that's a very useful molecule to trace. And again, if it's elevated, it's more likely in keeping with ATN, which makes complete sense, because if your tubules are trashed, everything is coming out in the urine. Whereas if it's pre-renal, we're not filtering as well as we ought to, because we're trying to hold on irrespective to everything, so it will be low, okay? Other things that you can look at in the urine are going to be lithium, interestingly enough, cystatin C, and uric acid, which I didn't know, can also be used.
Quick question, Carmen.
Yes?
Is it probenecid affects FeNA? Or does anybody know that? Like,
Does anyone know if probenecid affects FeNA? I don't know.
Urea, because some of those, like they're on that medication, probably won't work, but I just need to be sure.
I don't know that, that's I'm afraid. And then management, okay? So in terms of our management, what is going to be our general approach? So in each case it's going to be different because I don't know what the cause is going to be, but certain steps are the same for everyone. So what are they? You want to read out the first point?
Rule out obstruction.
Wonderful. How are you going to do that? So first you can ask the patient if they're passing urine, right? And if they said, yeah, I'm passing, no, it's not a problem. You don't feel a palpable bladder. Okay, if you're concerned or you're not sure, you could do a bedside bladder scan. But yes, otherwise, if you see something, you can catheterize the patient, okay, if needs be. So that's really easy, and that's the first thing to think about because it's readily reversible usually. Then what are you going to do? You read the second point.
Ensure good perfusion and volume status.
All right, how are you going to do it?
Do they have edema, good skin turgor, perfusion, maybe like an echo, like a renal artery?
More basic than that before we get there.
Fluids. Or blood pressure.
Yes, yeah, like what is their heart rate, what is their blood pressure, like you said, skin turgor. Sometimes difficult to assess volume status and hydration status in adults, unless it's really severe on any one spectrum. But these are all good ideas. And then what are you going to do about it? So what can you treat?
Volume status, yolks, fluids.
Yes, you can give fluids. If fluids doesn't work, what else can you do?
Right.
You can give presses, okay. What about if you've got too much volume? Is that ever a case of AKI? First years? Can you have too much volume and have AKI?
Yes.
And what are you going to do about that then? Yeah, you're going to diurese to get some of that volume off, right? And does that make sense? Does that make sense, medical students? Because we're trying to improve perfusion, right? So if there is excessive volume, okay, that's further force that the heart has to pump against, right? So we will, although it seems illogical that you're giving a diuretic to someone who's already got AKI, if you think that they're overloaded, it will actually improve their perfusion. And then, what is the third point, Eve?
Remove active insults that will add to injury.
Okay, so what kind of things can you do for that?
Get rid of medications.
Yes, perfect. Okay, so you're gonna get rid of any medications. Now, are you going to get rid of what kind of medications? Shout some examples out. Anyone in the room?
Acyclovir.
ACE inhibitors.
Okay, acyclovir. Why?
It's also causes injury perfusion.
Yeah, he said it. Crystal nephropathy. Okay, for the risk of. But you have to balance that, right? Maybe they need acyclovir because they have like bone marrow transplant or something.
So you would get rid of NSAIDs, or like if you can switch off different antibiotic medications, like the risk of using vancomycin and Zosyn, if you can switch it to something else that won't promote.
So in the first line, you can stop some direct nephrotoxins, okay? So NSAIDs.
Avoid contrast.
NSAIDs, ACE, no cath.
No cath.
So of course, you will. You'll stop. You can also really reduce the dose, right, to certain things that they're on. What kind of common meds do you think, or can you think of any common medications which can sometimes build up in patients who've got AKI?
Insulin.
Metformin.
So, hang on, wait. You said, what did you say first?
Insulin.
Insulin? Yes, okay, think about that for risk of hypoglycemia. Lopinox, what are you going to switch those patients to?
Just decrease the dose.
Or
So usually we switch them to heparin if their creatinine clearance is less than 30. Okay, and then someone else said something?
Digoxin.
Digoxin, okay, again another one to watch because of its narrow therapeutic window. And then what about things like morphine? Does morphine build up in the system? Yes, it does. Okay.
Metformin.
What about gabapentin? Does that build up? Yes. So, it's always just worth thinking, like, we know some obvious nephrotoxins, but there are many other medications which have the need to be renally adjusted. okay, to avoid further damage. And then just like Debbie said, you know, unless it's going to be life-saving, we don't want to give contrast, okay? That's another insult that we're hoping to avoid. And then looking out for the complications of AKI, which we talked about, anyone who you think is verging towards dialysis. So some things to look out for, they're pretty much the same as AIEOU and evolving anuria, okay? So even if you think you've seen someone, everything looks okay, you're dealing with everything appropriately, if the urine output starts to drop, that's an alarming feature, okay, that you need to go and reassess the patient and discuss. So my take-home points really are going to be the definition of AKI that we talked about, seeing that creatinine rise more than 0.3 within 48 hours, having more than a 1.5 baseline increment, or having less than 0.5 ml per kilo output in your urine for at least 6 hours. Be aware of the fact that this can be pre-renal, intrinsically renal, post-renal, or a combination of the both. Easiest things are to approach to rule out obstruction, optimize perfusion, and stop any further insults. Look out mainly in the inpatient setting for hyperkalemia or associated acidosis with AKI, and just be aware of the emergent indications for dialysis. All right? Let's do just 2 questions here, okay? And we'll do the old-fashioned hands up method. So 63-year-old woman is hospitalized for cardiac catheterization and unstable angina. History is significant for stage 3 chronic kidney disease attributed to diabetic nephropathy. Medications are heparin, metoprolol, losartan, amlodipine, atorvastatin, basal insulin, and prandial insulin. On physical examination, vital signs are normal. There's no JVD distension or lower limb edema. The remainder of the examination is unremarkable. Labs are showing a creatinine of 2.4 when previously, and a GFR of 24, okay? Question is, which of the following is the most appropriate peri-procedural measure to prevent AKI? So you've got hemodialysis, you've got bicarb, you've got normal saline pre and post, and you've got NAC therapy pre-procedurally. So hands up for A, hands up for B, hands up for C, hands up for D. Nobody? Yes, you're all right. C is the correct answer, okay? Previously, there was thought that preventing further AKI can be used or can be achieved by using NAC, but there is no evidence for that. Last question. 46-year-old woman is evaluated for a creatinine of 2.6 when her baseline creatinine just 3 months ago was 0.9. She doesn't have any symptoms, and 2 years ago she started losartan and amlodipine for blood pressure. A year ago she started omeprazole for reflux, and then she started naproxen for knee osteoarthritis. 8 months ago she then started atorvastatin. She's afebrile, her blood pressure is fine, and the rest of her examination is unremarkable. Her urine analysis shows a slight pH is 5.5, 1 plus erythrocytes, 3 plus leukocytes, leukocyte esterase, 1 plus, no nitrites, some pyuria, and leukocyte and granular casts. Okay? Which medication should be stopped here? So we'll do hands up for A, hands up for B, hands up for C, or D, or E. Oh, you guys are smashing it. Yeah, that's right. So you're going to stop the NSAID and the PPI, okay, for concerns of developing AIN. Thank you very much.
Question and clarification for medical students. So for indications for dialysis, it's not just symptomatic uremia. It's usually when you have like those end organs, that's when uremic encephalopathy, uremic pericarditis. I'm not sure if gastritis is there. That's what we're looking for, not just the itching or the, you see what I mean?
Any questions from the masters? Thank you very much for your time.